if you want to know what's going to separate the people who rise to the top, it's
Welcome to Specialty Stories. My name is Dr. Ryan Gray, and I'm excited to bring you another great guest here on the Specialty Stories podcast. If you don't know about Specialty Stories, my goal here is to bring you specialists from every field, from every walk of life, from every point of our country, from the academic world out to the community, to rural physicians, and many other places. And my goal is to really help expose you to many different fields that you may not have known about. Our guest today is a robotic esophageal and bariatric surgeon, Dr. Christopher DuCoin, talking about his specialty. We start the conversation with how Dr. DuCoin first became interested in bariatric surgery.
Yeah, it's probably hard to put a pinpoint on that. I feel like I was fairly young. Definitely in high school, there was a group of top students who, I think there's 5 of us who got to pick, you almost like go and shadow someone in the field you're interested in. And I remember in high school, I picked to shadow a surgeon. So I was definitely interested then. And then I think gastrointestinal surgery. I don't know what was the attraction to it for me, but it was definitely still in medical school when I really piqued my interest of going into general surgery. And then in general surgery, you kind of rotate through everything during your residency, and GI surgery just, struck a chord with me. All the different pathologies and everything from cancer to, weight loss surgery. There's just a lot to do. So I was fascinated by it.
What's the typical route? Because general surgery is one of those things that it just seems like there's exponential kind of paths after general surgery. For you and for your co-residents as you're going through the process of figuring out fellowships and what do you want to do next, what's the general kind of algorithm, if that's the best word for it, to figure this out? Is it I like poop, I don't like poop, I like upper body versus lower body? Like, how do you go through that process?
Yeah, I think it's such a unique question, I think, for each person, like how they take themselves through it. Usually, so, you make a decision that you want to do surgery, like we'll say general surgery, and there really isn't general surgery anymore. It's more of like you look at it as a 5-year training program and everything from cardiothoracic surgery to colorectal to vascular. And I always tell people, like, so we have a very large residency program where I'm at, and I usually tell them your first year, you just want to survive and try and do well on as many standardized tests as possible. But don't overwhelm yourself. Your second year, third year of your residency, you really want to dial down and look at every day as kind of like a job fair. Like, could you do this for the rest of your life? Right around your fourth year, you'll start thinking about fellowships and which fellowships you want to go to. Maybe you need to even take a year off for research to kind of tune up your application. And then usually you'll know where you're going to go your 5th year. And it's interesting, about 80% of U.S. General surgery residents will now go into some sort of subspecialty fellowship training. And, you kind of just figure out as you go through the program what your interests are. It doesn't take long. Pros and cons, each one of them. There's different lifestyles, different pathologies. The patients are all different for each organ system and surgical group. So, it's different for everybody.
What are some of the biggest myths or misconceptions around bariatric surgery that you have to deal with?
Oh, bariatric surgery, probably in particular, that it's like dangerous, that something terrible is going to happen. It wasn't a myth always. In the early 2000s, late 90s, bariatric surgery or weight loss surgery, had a decent level of morbidity to it, like sickness, illness. There, you get these leaks, complications. I mean, patients were really large. They're predisposed to perioperative complications, and really with the kind of the inception of a couple of surgical societies that really dialed down on appropriate perioperative care. We push the envelope now. I mean, my average weight loss patient stays in the hospital for about 23 hours, just short of a full day. They can be 600-700 pound patients doing major GI surgery, and they go home within 23 hours. I think it's pretty amazing.
Wow.
I really think that the sleeve gastrectomy, pretty simple operation. It's a gastric reduction surgery. think it's probably one of the safest elective surgeries we do in the United States, and that's all comers. That's like hysterectomy, knee surgery. It's just because we've really scrutinized it, and we make sure the patients are kind of prepared for the operation. We make sure the surgeons know what they're doing, and the hospital knows what it's doing too. So you can't just willy-nilly wake up one day and say, hey, I'm going to do a sleeve gastrectomy. It's a long process. It takes at least 6 months preoperative workup for the patient to get there. And the surgery takes about an hour, and they go home in 23 hours. So the workup's pretty impressive.
Wow. What are some of the traits that you think make someone to be a good minimally invasive surgeon, bariatric surgeon?
Yeah, that's a fun question, because everyone, you do robotic surgery. I do my entire practice is pretty much robotic surgery at this point. Little incisions, kind of real complex surgery. We do everything from weight loss procedures to esophagectomies for cancer through a couple little incisions. But you ask what the traits are. I think people they love to say playing computers as a kid and all this kind of stuff. And to me, it's just what's the trait of a surgeon, and it's grit. At the end of the day, it's you have to be really smart. I'm not really smart. I don't think I'm in the room with other physicians. I'm definitely not the smartest person. I don't think it's smart, but you got to be able to pass your standardized tests and jump through all the hoops that are going to get you in the position to get into residency. But if you want to know what's going to separate the people who rise to the top, it's grit. It's doing a little bit more than the average person or your peers. It's when you're tired and your body tells you to, go home, that you just need to take a nap, but your heart's telling you got one more patient to check on in the hospital. Are you going to be the person who's going to go home to take the nap, or are you going to go back and round on the patient, make sure everything's safe? I think that's what really separates just surgeons in general. It's like this cannot ever become a job. It can't be something it's a career. This has got to be, it's got to be something you love so much it's your hobby.
Yeah.
It's got to be just a part of who you are. I'd like to think I'm a husband and father first, but there's a part of me that definitely forever will identify as being just a surgeon, regardless of minimally invasive, robotic, whatever.
Yeah. Talk about those types of cases that you just love, that are the hobby. So many specialists come on and they talk about how one of the biggest misconception is, like, for emergency department, like, you're just going to see gunshot wounds and stab wounds all day, like every day. That's what you do. And there isn't enough focus on bread and butter cases to really help students focus in on a specialty. What's bread and butter for you as a minimally invasive surgeon, as a bariatric surgeon?
Yeah, right. I feel like that's kind of like, it's a little unfair, because I do work at a tertiary quaternary hospital, and I've kind of positioned myself where I'm lucky. I get to do some of the more complex cases that come along in some unique pathologies, right? So I do. There's a disease process called achalasia, where the esophagus essentially doesn't function. There's a couple really neat procedures, both robotic, laparoscopic, and even endoscopic. I went to Germany to learn how to do this like transoral surgery for it, and there's the bariatric cases and the esophageal cancer, and that's become the bulk of my practice. But when I started, 7 years ago now, I took acute care surgery call like everybody else, and bread and butter to me was appendectomy in the middle of the night, perforated colon, bad gallbladder, a hernia with stuck intestines in it, and I got to tell you, I think I do the cases I do now because I've found them extremely interesting, the pathology, the operation, the patients. But when I started, it was just operating. Like the bread and butter cases, I got just as much fulfillment. Like I really honestly did. An appendectomy where you take it out and the patient's good the next day. Feels great.
Yeah. Talk about for a lot of students going into medicine, they love the kind of Sherlock Holmes of being a physician. For you as a bariatric surgeon, is there a lot of diagnosis in your practice, or are you mostly there to fix what is wrong?
Yeah, so I wouldn't say there's like a lot of diagnosis, but there's a lot of doctoring. So remember we were talking before about like the perioperative, how the complication rates are so low. That's 6 months. There's a lot of medical management up front. So diabetes, hypertension, getting their sleep apnea under control. It's almost like they go through this rigorous program. So it is a little bit of, I would say, operative preparation. But for bariatrics, there isn't that kind of like, you know, aha moment. I found out what's going on. You see your patient population, you know that morbid obesity is the cause of so many of their issues. I will tell you one of the fun things that most students and residents and trainees for that matter don't get to see. So, we do this long 6 month preoperative workup. We do the operation. I mean, even the fellow that's a trainee a year after residency is only with me for a year. But the best part I like about bariatric surgery is 6 months, a year after the operation, they come back in, and I'm not kidding you. Their diabetes is resolved, their hypertension's good, their sleep apnea is different. We keep these little pictures in the electronic medical record of what they look like. Almost always a year visit afterwards, I don't even recognize them. They've got a neck, they've got a chin. It's a neat thing to see. So.
I've had a little experience in bariatric surgery just through my internship training on the surgery floors, and one of the things that came up I remember was potentially some of the psychology around obesity and the patients turning to other things to turn their addiction to. If they're addicted to food, they turn to gambling, to drugs, to some other addiction. How much of psychology is involved in what you do as a bariatric surgeon?
Yeah, I'd probably say that there's some sort of underlying psychosis in probably about 90% of the patients we operate on. And I'm not saying like, major depressive disorder or bipolar, but something. They've had some sort of traumatic event or something. That's why they all have to be evaluated by a psychologist. And it's not kind of like, okay, you saw the psychologist, check, you're ready to go to the operating room. It's they'll follow up with the psychologist, they'll work with them. So I don't really know how many switch from this to that, but I just know that there's a psychological aspect to this, the disease process. And some people it's more severe, and others it's not. And you do get your horror stories every once in a while where a patient went from overeating to over drinking or things like this, but they're very, very rare these days.
Yeah. Do you, as an adult bariatric surgeon, obviously, has the society looked at the ACEs, the Adverse Childhood Event Study? Do you know about that?
No, clue me in on this one.
So it's the ACEs is a score for adverse childhood events, so trauma from a childhood, and just there's really strong correlation to addiction, to obesity, to lots of other things. So it'd be interesting to add that score into your workup for patients.
Yeah, so I do just adults. My partner does the adolescent patient population, and we feel very comfortable operating down to about 16 to 18-year-olds, but we've even started going younger. We kind of opened the doors up on a little bit more as we realized, there's 14, 15-year-olds, type 2 diabetics that are insulin dependent already. So, yeah, the trauma behind of what gets a 14-year-old to morbid obesity is, I think it's a real thing, that's for sure.
Yeah. What does a typical day or a typical week look like for you?
Yeah, so it's a great question, especially when I kind of talk to the medical students on this one. So I was in my old institution, I was a clerkship director, and I worked a lot with the residents and the medical students. And I would get this one all the time, and I would always tell them that some of my good friends, he's a surgeon, and his wife is a family practitioner, and my wife is a nurse practitioner. And my wife and I, he and I were saying the same thing, my friend. We get up at the same time, we go to work with our wives, very similar times. We all come home at the same time, essentially. So my wife and I, maybe I'm a little later than her. I've got to kind of do some administrative work, but the big difference. So the lifestyle isn't that bad once you get to being an attending, once you make it to the end of the road. Now the difference is if you look at what it took to get through training for me, and maybe versus like a family medicine doctor or even an internist, very, very different.
Yeah.
in 5 years, you have to not just be taught how the entire human body works, all the pathology behind it, and then how to operate on it. I mean, it's just a lot. So I think the real critical moment is in medical school during your third year, really paying attention to how the residents' lives are and to ensure that you can get through that to the other side. If you're just around attendings all the time, you're like, oh, it's not that bad. They come in at 7:38, they operate, they're home by 3:30, 4, 5. That's not bad. You have to look at the residents who are coming in at, at 4:35 in the morning, staying till 8 o'clock at night. Like that's the tough part of training.
Yeah. It's like regular boot camp versus like Navy SEAL training.
Yeah.
There's a difference there. So talk about that training path a little bit. What does it take to become a bariatric surgeon?
Yeah. So, so it's the standard kind of role we were saying before is third year medical school. You kind of got to make your decision what you're going to go into. Fourth year, end of your third year, you apply. Fourth year, you kind of match. You start your residency. Residencies 5 years in most places. Some are 7 if you're going to go to like a very, very academic heavy institute that makes you do 2 years for research. After residency, most people do a fellowship. And then after fellowship, you kind of can start your position. Now, I did something a little different. I did a year of fellowship I'm in Florida now. I did my fellowship in California. And then I went and did actually additional training in South America and Argentina. And then I did additional training in Germany and Frankfurt. They were just doing additional procedures I wanted to kind of bring back to the United States. And then you kind of either start a program or join a practice and take it from there.
What is it like to go through this training? And I'm very interested in the South America, Argentina, Germany kind of aspect. For you to go through this training, how do you learn about what other people doing in other countries and figure out that we're not doing it here and you want to go learn that so you can bring it back here and kind of be the trendsetter?
Yeah, so I did a lot of reading, and these things piqued my interest. There's like and I do kind of two things, right? I do bariatric surgery about half my practice, and esophageal pathology, just straight esophageal related diseases is the other. And I got really fascinated with something called achalasia. I'm really fascinated with esophageal cancer. In South America at the time, they were doing. So I went to South America to learn something called an omega loop bariatric procedure. It's the way they were reconstructing their gastric bypass. And when I was reading it in this journal, I was kind of thinking to myself, this would be perfect for the robot, like, because we have a hard time. The robot at that time, you dock it and it couldn't move around that much. It was like the Atari, and now we're up to like a much fancier version. But at the time, it couldn't do too much. So I went down there, and other people were doing the same thing. I'm by no means taking credit for this, but I learned this omega loop technique. And when I came back to the United States, I could implement it. They were doing it laparoscopically in South America, but it was easy to convert it to robotics. And then in Germany, I learned how to do this transoral surgery, essentially, for a disease process called achalasia. Now, if you ask me, like, so how did I find it? So I read about it, and then I went to a fellowship where I knew they were doing it at the fellowship. And then when I talked to my mentor at my fellowship, and I expressed even a higher level of learning and kind of asked him where he learned, he said, oh, this is where I did it. I said, can I go? And he was like, if you want to pay for it. So I got a credit card out at the time and went and did that.
Oh, that's cool. And obviously, hopefully helpful for you and your patients to have that sort of training. So it's great.
Actually, I'm going to say, yeah. So I really wanted to be in academics. I really wanted to be at a hospital that was affiliated with the university. And back to that original question, he said, like, what's a good trait of a surgeon? It's grit. And I think that little bit extra, and you got to remember, I went to elementary school, middle school, high school, college, grad school, blah, blah, blah. It goes on and on and on. But that little extra time, that little tiny bit, that extra like year essentially I put in South America and Germany is what set me apart from all my peers. And I think that's what landed me my first academic job that was maybe different than everybody else. So yeah. I would just kind of tell students that if an opportunity ever presents itself, or it might seem like a little more work, but it's going to live with you forever on your resume, CV, go for it.
What does call look like for you?
I feel bad answering this. So we'll go back 7 years ago. So when I first, it was rough. I took when I first started, I did every third week. I managed the ER call at Tulane Medical Center. Again, everything we had a gunshot wound dropped off on the doorstep. It was everything that came in for a week. I would do it. I'd do it from what was it? It was like 6 a.m. to 6 p.m. while I was also trying to build a bariatric and esophageal practice. And then on the weekend, I was the guy all weekend long. So, I think it was like 6 p.m. on Friday to 6 a.m. on Monday. And then it would get switched off to the next person. But that's what I did for about 3 or 4 years. That was kind of rough at that moment. Where I'm at now, I think I've moved along nicely. So I really don't have to take too much call at all anymore, which is nice. There's a point in your career where you want call, you want to be busy, you want your hands to move, you want to operate on everything. And then I think you reach a point where, you've got a large enough clinic volume of patients that you don't need to take call too much. So we have call schedules established, but for the most part, the in-house acute care surgeon or trauma surgeon can usually handle anything. Probably the only thing I still go in to help out with are esophageal perforations, like 4 Hobbs or something like that. I'll get a call and they'll ask me to come in. I'll usually try and help out if I can.
What does it look like for complications of your own patients? Is it just dealt with by whoever's staffing that day?
No, so that's different. I don't look at that as call. That's just care. So we all get trained, and we're still in the realm of if it's your patient, it's your patient. So if your patient's not doing well on a Saturday or Sunday, you're going to be there to take care of it. And that's kind of how our whole group's set up. We definitely look out for each other. If someone's going out of town and to a meeting or a wedding or whatever, and their patients are doing well, we'll all cover. But there's usually a very cordial exchange. You tell your patient, Dr. So-and-so is going to help me out. I have to fly out of town for this wedding. Most patients are very responsive, but that's not the norm. The norm is, if you've got a complication, you're going to come in and take care of it.
Yeah.
But like I said about the bariatric stuff, we're very fortunate where we've evolved to. There's really very few complications these days. The esophageal stuff is a little different. It's a high risk surgery, so you do get complications there.
How competitive is it to match into a minimally invasive surgery and to become a bariatric surgeon?
Yeah, that's a great question also. So again, I kind of just said my lifestyle's pretty good. I think I'm compensated well. I fit in an academic model. So the thing that has happened recently is where, people used to want to do cardiothoracic and trauma and all these kind of, for easy way to phrase it, poor lifestyle surgery. It's become very competitive because we have a very nice lifestyle. We started talking here, what time is it, around 4 o'clock? I could have easily just gone home. It's a nice lifestyle, now I do a lot of other things. I'm always working with residents, students, got my, projects going on, but for the most part, I think it's become extremely competitive. I think last year it had a match rate almost as what you'd see in plastic surgery. And I attribute it. I'd like to say it's like, it's because we're all really fun people. And robotic surgery is really fascinating, but I do think the lifestyle has become a much bigger part of students' decision process.
For the osteopathic student, what should they do to help kind of overcome any sort of negative bias out there?
That's a great question. So I really hope that there isn't too much anymore. There probably will be. I don't think we look at those applications. So I sit on our resident review committee, and we don't screen out or look at those applications in any other way. I would say it's just become so competitive to get into general surgeries. What do you do no matter what? If you're allopathic or osteopathic, what do you do to set yourself apart? One of the bigger ones, especially as the step moves to a pass-fail, what I would suggest is just research and network.
Yeah.
If you can get a couple extra lines on your CV doing some research projects, and usually I always tell people research is twofold. One, it gives you a line on your CV and kind of fills that up. But usually if you're doing a research project, especially as a medical student, you're actually building your mentorship network, because whoever's doing the research project with you is most likely also your mentor. And that's the person who can make a phone call for you. The phone call is probably the most important thing. Someone who, you go on your interviews, you're really like this program in Kentucky. It's someone who's going to pick up the phone call that program director on your behalf. And that will be the thing that, I really think sets you apart, regardless of, the letters after your name.
Yeah. Talk about that transition to STEP being pass fail in terms of students really needing to network and get out there and do research. For someone who's not in a very strong area where general surgery isn't a big thing. Obviously general surgery is one of the most common things, so it should be general surgeons around. But if someone's out in a more rural setting for a medical school that doesn't have a lot of connections, what do you recommend they do?
Yeah. So the step one going pass fail, I think, is going to be, so from what I gathered, it was done to decrease student kind of almost like anxiety, if you will, around a singular test.
Yeah.
And my kind of counter argument to that is the anxiety of that single test might get dissipated, but it's still going to be there. If you're going into a competitive field, you're going to have to perform or outperform your peers to a certain extent. So it'll just get, maybe your shelf exam on your, third year rotation gets weighed more heavily. Maybe we're clearly going to mandate, I assume, step 2, because step 2 still isn't pass fail. So we'll want, right now where you could apply with just a step 1, that probably won't. In the future, you'll have had to take step 2 and done well. So there'll just be different areas to look at. But if you're out in a rural community, and let's say and you don't have a ton of exposure to general surgeons, or you're not really clicking with anyone, you're not making a mentor, there's no research group to join or anything like that. When you start identifying that you want to do this, and maybe regardless, my wife would give me a hard time if I did that. Regardless, you had you had the mentors. I think joining, and I hope this isn't a shameless plug, but for the American College of Surgeons, there's a student section. I think it would help out these kind of situations quite a bit. We do everything in the college, from running small mentorship programs to, we call it speed dating, where you kind of meet various people and see if there's anyone you click with for mentorship. But I think the college is a great resource. I know they really, we're always looking for students. I think of myself as a surgical educator. I get probably the most fulfillment out of watching, a student, the light go off in their head that they want to do surgery, and a resident do well. And that's kind of the principle behind the colleges. We want to help the next generation. So I would say join the American College of Surgeons.
Yeah. It's funny. I put up a social media post the other day. It was like the levels of kind of awareness of why you want to be a physician, and like level 5, the biggest was, I just want to cut people.
Welcome to surgery.
Yeah, that was my goal. I'm like, I just want to cut people and put them back together as an orthopod. Talk about the for the future primary care physician watching this, listening to this, what should they know about what you do day in and day out, or 50% of your time as a bariatric surgeon, to help their patients with their weight loss, or help their patients maybe come see you sooner? What do you want them to know?
Yeah, I would say, let me give it, before I do that, let me give a story, and because I think this will kind of sum it up a little bit. So I was doing, again, bariatric surgery in New Orleans, and the chair of endocrinology, I was passing him one day, and all these skinny little old guy walks up to me and punches me as hard as he can on the shoulder. What was that for? Do you care about diabetes? I said, of course I care about diabetes. We should all care about it. He goes, do you care about diabetes? I was like, yeah, I care about diabetes. I dedicated my career to diabetes. And I was like, okay. He goes, I can only treat diabetes. You have the potential to cure it. So I think if I could tell a primary care doctor, and this isn't, believe me, I'm not trying to say bariatric surgery is this thing that cures diabetes, right? It will help. Sometimes get great results. But I would say do your research, learn about the outcomes. I think people get really scared that their patients are going to die. I mean, I've never had a patient even come close to anywhere near death. Um, and look what the outcomes can do when someone loses, 200, 250 pounds. I mean, they really do. Diabetic resolution, hypertension resolution, kidney function returns, fatty liver disease, NASH improves, sleep apnea goes away, osteoporosis gets better. I mean, just the list goes on and on. So if you saw, I would say, a morbidly obese patient, like it should just ring a bell in your head to get at least a referral to a bariatric surgeon. And it's not like I operate on every patient I see either. And the ones that are either too sick or not candidates, we've got a complete medical weight loss program we run also. So we're in the, I always tell people, we're just in the business of making people better.
Yeah. How do you walk a line? There seems to be a lot of this body positivity movement that I am healthy no matter what my BMI is. How do we as physicians kind of walk that line between educating, but also making sure that we're empathetic to patients and really doing what's best for them and what they want as well?
Yeah, I think it's like this, and it might be blunt. Don't be a jerk. Don't put your head in the sand in the same capacity. You can't call anyone fat. Like it's not right. It's not appropriate. It's derogatory to me. And there's all the other words that go along with that. Um, but we can't endorse sickness either. And that's what I talk about, putting your head in the sand. So if you've got a morbidly obese patient with type 2 diabetes on insulin, and you think it's not your job as a physician to educate them on their weight, I'd say take your head out of the sand, man. Like, your job is to educate them that their diabetes, which is an extreme burden on our society, is due to their obesity, and help them get better. And you have to. I think that's probably, Ryan, the biggest. If I can make a point about this, talk to your patients. Don't sit there and talk about their diabetes, hypertension, sleep apnea, blah 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 blah, and be scared to say it's because you're overweight. They are not stupid, and I think that's the thing. It's like we just think that I'm not going to talk to them about their obesity. They know their obesity is causing this. They're begging for you to help them. So I'm not saying go around and start hey, everybody needs bariatric surgery, but in the same sense, sick patients need help.
Yeah. What do you know now that you wish you knew before going into bariatric surgery and minimally invasive surgery?
Oh man, what do I know now that I wish I would have known? I wish I'd known that you and I'd be talking today, and that my career would end up where it was. I think there's so many hurdles you have to go through, and so many things. And I calculated this attrition rate once of what it takes to get like the college freshman to a fellow of the American College of Surgeons, and it's like a shot in the dark. You actually make it here. And I think, just if I could go back and tell myself, keep your head down, work hard. Don't you'll get discouraged, but just keep pushing through. And if you can get that mental picture in your brain about the end result, you can get yourself there. But never be satisfied with where you're at either. Just keep trying to go, keep trying to push yourself forward. And I would just kind of tell myself it's going to be okay. I wouldn't tell myself like, oh, there's a new robot coming out, or it's going to be super fun, or anything like that. I'd just rather tell myself, keep going, have belief in yourself, and that's probably the most important thing.
Talk about the robot aspect. So a lot of students listening to this may hear robot and go, that's really awesome. I want to play with a robot. And other students will say, well, I was really interested in bariatric surgery or minimally invasive surgery, but I'm not so sure. I'm not a tech person. I don't know if I'm good with my hands. How scared should the technology, how scared should a student be of the technology, or is that something they can learn as they go?
Yeah, it's definitely a learn as you go, because the technology is going to keep cruising at like light speed ahead. So there's a third-year student right now who goes into the operating room and sees the newest robot and sits on it and thinks it's super cool and it's got 3D and we're operating, we're not even standing at the patient's bedside. By the time they're in residency, it's going to be different. Like, it's moving so fast. Technology's improving so much that it's going to keep going. And the robot is really neat. It is. I'm a believer. It's not just revolutionized, but it is revolutionizing surgery, what we can do, what kind of incisions, and it's only going to get better. If you're someone who's like tech adverse, man, I mean, it's an act of, I think, like, small miracle that you and I are talking today, because I was like, how do I work this? And then I can do robotic surgery. Anybody can. Now, if you're someone who's like, I'm not good with my hands, I have a hard time tying my shoes, and I'm kind of clumsy, surgery might not be the best thing for you. I mean, you do have to have a decent amount of dexterity, understand spatial visual kind of setup. But usually, I think most people, especially, I mean, medical students are brilliant, right? I think most people are pretty self-aware of selecting themselves out if it's for a physical limitation that they can't do it. I've had to coach a couple students who physically couldn't do it, and those are probably the most painful conversations. But at the end of the day, they know that it wasn't it was a non-practical dream that and that those are probably the hardest talks.
One of the biggest fears around the radiology world kind of for a long time has been outsourcing to other countries, right? You get a bunch of radiologists in Australia that now do all the reading because of technology and being able to read scans from afar. Do you think we'll get to a point potentially with bariatric surgery, the minimally invasive surgery with robots and latency of the internet, to where someone in Australia can be operating in a OR here in Iowa?
So they did it once from, I think, the UK to New York or something like that, and there was too much of a lag. It was I forget what kind of cord they used to connect, but there was it was so interesting. It was like on the order of nanoseconds, but it was too much. The brain could compute it, was computing too fast, and the lag made it really hard.
Yeah.
So, I think technology-wise, like, if we wanted to build some sort of like fiber optic cable that allowed like instantaneous like data transfer, like, could it be done? Probably. Will it be done? Probably not, just because there's really no need for it. There's no one who's like that super specialized that you need your surgeon in Australia in the middle of the night, like daytime procedure in New York. But what I would say, and where I think the magic 8 ball is taking us, isn't not to like telemedicine or remote surgery or anything, but I think artificial intelligence. If I had to put my money on a stock, it would be AI. I think it's coming. I think it's coming in force. I don't think it'll be in my lifetime or my kid's lifetime, maybe, but I do think in the future there'll be a large part of medicine, and we could talk outside of surgery, because I think like primary care and even the emergency room are kind of under threat from AI. But I think surgery will go the way of AI, and then a couple of generations they'll look back at surgery as complete barbarianism, that we used to cut people open out when all you have to do is type in this genetic sequence and inject this thing, and the thing takes care of itself. So, it's fun to speculate about the future. I think I've got a career. I think maybe my kids do, and I honestly think artificial intelligence is coming quickly.
Yeah, definitely. I think we as humans, we underestimate what can be done with tech, but I'm a huge tech nerd, and I think it's coming. It's coming strong. So, Elon's on top of it. I don't know if you've seen what he's doing with his Neuralink, but that's pretty awesome.
No, I've seen a lot of like the ER algorithms, primary care algorithms, which are just phenomenal. It's kind of like, you're like, oh my God, I studied that for like so long, and the computer did it in seconds. And but yeah, we'll see. Elon Musk.
What do you like the most about being a minimally invasive surgeon?
Yeah, I think I like the I like the pace of it, and I like the return on my effort. So, it's just gallbladder. Someone's got a bad gallbladder, they're sick, maybe then they're dying. I take the gallbladder out, the next day they're better. I think I really enjoy that. I do miss a little bit of the personal connection that maybe you get when you're following a patient for a very long time. I do get that with bariatrics, though. Like I said, we follow them for roughly 7 years after their surgery.
Wow.
But I think that's it. That's what I get the most out of it. the that it's kind of probably cliche, but that I feel like I'm part of the medical treatment, right? It's like I didn't order the antibiotic and you gave it to them and the gallbladder got better. You ordered the surgery and you took them in the operating room and they got better.
Yeah. What do you like the least?
Probably anyone who's been doing this long enough will tell you I like the least probably the paperwork. There's a lot of administrative stuff that goes along with it, and then there's like a business side to medicine and a legal side to medicine that's pretty intense these days. I mean, it builds entire fortunes and corporations just on the back of the medical profession. But and it is at this point.
If you had to do it all over again, would you still be a minimally invasive surgeon?
In a heartbeat, yeah.
What final words of wisdom do you have for someone listening to this who maybe is now interested in bariatric surgery or minimally invasive surgery?
I wouldn't even tell them about that. I'd say if you're in medicine, just find your hobby, find your passion. Try, like the Socrates thing, like find what you love and you'll never work a day. Like really spend time your third year of medical school, like really picturing what you can do. Even before that, try and envision what you can be. And if you're, I think a lot of us can be fortunate enough that if we do find that it becomes not a job anymore and it's something you genuinely love. Don't tell anyone I would do this for free. I love it. I genuinely do, and I would wish that for everybody else.